Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of our show. Today, bringing you another really great guest involved in creating a better tomorrow for many people out there. Today, we have the honor of being joined by Dr. Susan Domchek, who is Executive Director of the Vassar Center for BRCA Cancers, Abramson Cancer Center, Director of McDonald's Women's Cancer Risk Evaluation Center, and Vassar Professor in Oncology, Permanent School of Medicine at University of Pennsylvania. Dr. Domchek's work focuses on the genetic evaluation and medical management of individuals with inherited risk factors for cancer. She's been particularly interested in developing new cancer therapies, including her work on the development of PARP inhibitors for breast cancer patients due to genetic risk factors. And she's also involved in this really fascinating new domain of immuno-interception, a way to really, target cancer at extremely early stages before they become malignant. As an elected member of the National Academy of Medicine, American Association of Physicians, and American Society of Clinical Investigation, Dr. Domchek is also a member of the American Society of Clinical Oncology, for which she served on a number of committees. She's a significant contributor to the oncology literature, with literally hundreds of articles appearing in scholarly journals, including New England Journal of Medicine, the Journal of American Medical Association, and the Journal of Clinical Oncology. She also serves on a number of editorial review boards, as well as on the Scientific Advisory Board for Breast Cancer Research Foundation. A lot of really important and interesting subjects to get into today. Honored to have her with us. Dr. Susan Domchek, thank you so much for taking the time to come on the show today.
Well, thank you for your kind introduction, and I'm really thrilled to be here today.
It's great having you. Before we get into BRCA and breast cancer and all the things we're going to be talking about, I would love to hear just a little bit about sort of the early days, because as people that watch the show know, I like to go back in sort of the literature and look at what you were doing sort of in the very early days. And it was interesting before you published your first paper on BRCA or even on breast cancer. In the early 90s, you were involved in the development of these really interesting peptide derivatives, this potential chemotherapeutic agents. And I'd love to hear the beginning of the story of sort of where it all started out in terms of sort of pharmacotherapeutics for cancer.
Sure. Well, I was an engineer as an undergraduate, and then ended up going into medical school. And when I started medical school, I was at Harvard Medical School. I was trying to decide how much I wanted to be in a basic research lab, with pipettes and tubes and all that sort of thing, versus some other form of research, or none at all. And so as part of that, I got involved in a research lab at Joslin Diabetes Center, but they just happened to be working on peptide interactions. And the actual thing that I was working on at the time, SH2 domains, ended up being very important in cancer. That was not specifically what we were working on. I was working on some very, very basic science, which goes to show you that you never really understand the work that you're doing and how that's going to evolve. And then I was in medical school, and I graduated from medical school in 1995. And that was actually when BRCA2 was cloned. So BRCA1 was cloned in 94, BRCA2 was cloned in 1995. And just along the course of listening to what was evolving in that field, I got continually more interested in the type of research that involves, patients and how we apply basic science principles to trying to improve the care of patients.
You're mentioning BRCA 1 and 2. This is an area that you've spent a long amount of time on. We have genes here that are tumor suppressors. The proteins they produce perform these very critical functions in DNA repair. And when things go wrong, they're clear drivers of disease in both men and women. They have similar names, but they have some differences in that they're sort of on different chromosomes and they act a little differently, and some of these different complexes and all the interesting ways they interact to suppress cancers. Walk us through this a little bit. Just I know you talk about this a lot, but just for our audience, if you could sort of just introduce us to the genes, their normal function, a little bit about what we know in terms of both men and women carriers today.
Absolutely. So as you mentioned, BRCA1 and BRCA2 are genes that we all have. They stand for breast cancer 1 and breast cancer 2, because you might think we're creative and clever, but really not so much. And these are genes that were discovered initially by a woman named Mary Claire King, who recognized, along with others over the history of the last 100 years, that there were families that had a lot of breast cancer, that had too much breast cancer. And actually, specifically, there were families that had breast and ovarian cancer linked together. And it's hard to explain how much science has changed, because now we have the whole genetic code, at least the exomes, the coding portions of the DNA, completely sequenced. But at that time, they had to almost do hand-to-hand combat to figure out what parts of the genes were, which genes were, what part of the DNA was linked to these families that had too much breast cancer, too much ovarian cancer. And this was by a technique called positional cloning. And even when they got down to exactly where in the chromosome it might be, it still took years for other groups to then clone the exact positions of BRCA1 and 2. And when those genes were cloned, so now all we know is that there's an area of the DNA that is altered in families that have too much breast and ovarian cancer. And that was all that was known when BRCA1 and 2 were cloned. So it was not known what these genes did, what the proteins that were made by these genes did. And certainly we didn't know what to do about it. And since that time, we understand that BRCA1 and BRCA2 are critically important in repairing DNA damage. So it's good to have BRCA1 and BRCA2. Sometimes people say it the other way, but no, we all have BRCA1 and 2. We want to have those genes. They help repair a specific type of DNA damage that's called double-stranded DNA break. And it's only when those genes are malfunctioning that we have an increased risk of developing cancer. And that increased risk of cancers is predominantly breast and ovarian cancer for women. For BRCA2, there's also a very significant increased risk of pancreatic cancer, male breast cancer, and prostate cancer. So BRCA1 and 2, as you said, they are related but distinct. They have slightly different risks. They're on different chromosomes, but they function together in the cell, both to help repair double-stranded breaks.
Responsibilities, those important housekeeping responsibilities, clearly put them both in the category that when things are wrong, they are drivers of disease. I mean, there's a lot of genes we related to cancers. We're not exactly sure if they're drivers or passengers along for the journey, but here, clear drivers of oncogenic transformation. Talk a little bit about the role of screening in sort of the current armamentarium of tools that we have, because this is an area where we can screen our somatic tissue, whether it's the breast tumor or other tumors that happen, but also because these now can go generation to generation, we can look at germline as well with today's tools. So walk us through a little bit of the roles here of both somatic and germline screening, and a little bit of sort of how these tools are used today.
Yeah, so the first, just to, as you did, just take a step back and say, what do we mean by germline and what do we mean by somatic? So germline are the genes that you're born with. And in general, when we do genetic testing for germline, we test white blood cells. That's what we do. We draw your blood, or we have you spit in a tube. Both do the same thing. We extract DNA from the white blood cells, and we sequence that to see whether there are inherited mutations mutations, or when we say mutations, we just mean an alteration in the gene that makes the proteins not work. That's really what a mutation means, is that it impacts the function of the protein that's made by the gene. So if you have an inherited gene mutation, that increases your risk for these cancers. But as you said, things can be acquired. And by that, we mean that you're sitting there and your cells are just sort of sitting there happy. But all of a sudden, through the daily insults of life, be that pollution or cigarette smoking or alcohol, there are constantly changes in your DNA. And usually, these mechanisms repair them, but sometimes they don't. So you develop acquired mutations in cells, and in a tumor, you can have all these genetic changes in the tumor. And that's what we mean by somatic mutations. And so BRCA1 and 2 mutations, most of the time, are inherited through your germline, inherited person to person to person. And but sometimes they can only be in the tumor itself. And that's important too, because as alluded to, if you have an inherited gene mutation, say I have an inherited gene mutation, each of my children has a 50% chance of inheriting it from me. But if the mutation is only, say, in the tumor, that can't be passed on generation to generation. Both of them are important, though, in what we'll talk about, I'm sure, later, which is how we treat cancers that are associated with these mutations, be that inherited or be they acquired in the somatic tissues.
In between, the period that you were talking about when these genes were first identified and we learned more about what they do, to sort of the period, and we'll get into PARP inhibitors and a lot of your work in drug development in a little bit, but in between those time frames, what was sort of the standard recommendation? I have my screening here. Oh yes, BRCA positive one. What was going on sort of in sort of the ecosystem at that time, in terms of how, very patients or in general, what were the recommendations during that time period?
So we were able to establish pretty quickly that if you had an inherited mutation in BRCA1 or 2, that your lifetime risk of breast cancer, if you're a woman, was as high as 70%, which is very, very high. Remember, the lifetime risk in the general population is in the 13% range. But almost more importantly, we realized that the risk of ovarian cancer was extremely high. So for a BRCA1 mutation carrier, that risk is 45% or higher. For BRCA2 is up to 20%. And that is compared to sort of 1 to 2% in the general population. And ovarian cancer, we really don't have effective screening for ovarian cancer. And unfortunately, most ovarian cancers are caught at a late stage. And most women with late stage ovarian cancer do not do as well as we'd like them to do. And so one of the first actions that was taken with BRCA1 and 2 mutation carriers is to preventatively do in a risk-reducing fashion, remove the ovaries and the fallopian tubes to decrease the risk of ovarian cancer. And although that seems dramatic, we don't have effective screening, and this is such a difficult condition that's what we started to do, and we could demonstrate that decreased the risk of ovarian cancer and led to women living longer. We're still looking for better screening. We're still looking for better options. But one of the most effective things that you can do for yourself if you have a BRCA1 or 2 mutation is to remove the ovaries. That was before we really understood any of the biology. That was just sort of epidemiology and being practical. For breast cancer risk, we know that doing breast MRI gets you a long way, because breast MRI, in addition to mammograms, diagnoses cancers most of the time at an early stage, and most women with early stage breast cancer do well. So women have a choice between MRI screening, more enhanced breast screening, or to have their breast removed to reduce their risk of breast cancer. And that's a little bit more of that's a more nuanced conversation, because we do have screening for breast cancer. For ovarian cancer, we're still looking for better options than removal of the ovaries.
Yeah. Extremely dramatic requirements at that time, and this obviously leads into your search for, ultimately how we can develop therapies that either treat, potentially prevent these cancers. And one of the areas that I mentioned in the bio that you spent a lot of time on, a very important target in this research, has been a PARP, which stands for this poly-ADP ribose polymerase, another really important protein for repairing DNA. But in this case, we're going to be using it. Our strategy is going to be a little different because we don't want to repair these damaged cells. We want to help. We want the cancer cells that are also using these mechanisms not to repair themselves and die. So there's a little bit of, sometimes we think repair. Oh, okay, no, but using a slightly different strategy here. I wonder if you could just talk a little bit about PARP in general, and a little bit because your focus has been on olaparib, which is a PARP inhibitor that's used for some other cancers. But take us through a little bit of what's been involved, specifically in the clinical development here in your organization.
Yeah, one of the things when you think about cancer and how to target cancer, what we've targeted for many years is things that are turned on. So think about it that way. It's kind of easier to target things that are turned on because you can develop a drug and turn them off. It's actually harder to target drugs that are turned off. So when you think about breast cancer, for instance, we've targeted estrogen receptor. We've targeted something called HER2. These are all things that are turned on. But if you take a BRCA1 related cancer, you're born with one bad copy of BRCA1, and then at some point when the tumor develops, almost always the second copy is lost, so that there is no functional BRCA protein in the tumor. So how do you target that? It's lost. And this is where science is just so incredibly cool, which is that people who are working in yeast biology, so they had nothing to do with BRCA1 or 2. They were just playing around with yeast and understanding DNA damage repair in yeast. And what they figured out is that this concept of synthetic lethality. And that's if you have one pathway that helps the cell function and you shut it off, sometimes nothing happens. And that's because another pathway is also helping keep the cell. There's redundant pathways. So if you target one pathway, nothing happens. If you target the other pathway, nothing happens. But if you target both, you have synthetic, because you're targeting both, lethality, which is the cell can no longer survive that insult. And so what was found out about these BRCA1 and 2 related cancers is that if you then target this other pathway, this PARP pathway using PARP inhibitors, if you shut that off too, the cells could no longer survive that insult if BRCA1 and 2 were inactivated. So it was a way to kind of selectively target cells as well, because in normal cells, BRCA1 and 2 works. So if you give a PARP inhibitor, it doesn't do that much to the cells. There's, of course, always side effects. But this was a huge breakthrough in medicine, this synthetic lethality targeting of cancer. And so although BRCA1 and 2 were the real first example of this, now people are really interested in this approach for all sorts of cancer types, which has been really exciting.
Can you say a couple words while we're on the topic of PARP inhibitors about, unfortunately, just like a lot of, in this era of smart drugs, we still have, cancer cells like to survive. They're, evolutionary, masters at, finding ways to escape and do other things. Insights regarding what we know about PARP inhibitor resistance today, based on some of the clinical work you've done.
Yeah, and to take a step back, these drugs, to give you an idea of their impact, they are different PARP inhibitors, and there are a number of them that are FDA approved: olaparib, rucaparib, niraparib, and talazoparib. And yes, they all rhyme, and they're all ridiculous names, but they're all in the same class of drugs. And they have FDA approvals for BRCA1 and 2 related breast, ovarian, prostate, and pancreatic cancer. There's also approvals, a little bit more broad approvals in ovarian cancers that are sort of BRCA-like, if you will. And these drugs have been incredibly effective. They are more effective the earlier you give them. That's for certain. So if you take an ovarian cancer individual who has a BRCA mutation and has gotten her chemotherapy and then give a PARP inhibitor, those women can do well for a very long period of time. Likewise, in early stage but high risk breast cancer that's associated with the BRCA1 or 2 mutation, we now know that after getting all your usual treatment, chemotherapy, surgery, radiation as needed, if you then give a PARP inhibitor, such as olaparib, for a year, we improve women's survival. They live longer because we gave them a year of olaparib. And actually, that's a huge deal because in breast cancer, that's the bar we have. We need to show that we improve survival. So those are all the good parts. As you point out, no drugs are perfect. They do have side effects. And in individuals, particularly with advanced cancer, many individuals' cancers start to grow back again. And the mechanism of resistance to these drugs is complicated. But one of the mechanisms of resistance is actually a little bit, in my mind, kind of creepy scientifically, which is the tumors develop another mutation, which helped restore BRCA1 and 2 function. And when you start to think about how smart biology is, like that's pretty crazy because there could be all sorts of mechanisms of resistance, but these, what we call reversion mutations, are very unique. And so we're still trying to sort out how to prevent that type of resistance mechanism from developing or how to specifically target it because it is so unique. Maybe there's a way that we can make that work for us.
Well, laying that groundwork, and clearly you pointed out, we need better screening. We need a whole suite of better therapeutic options, not just breast, ovarian, many of the other cancers related to BRCA. Enter the Bassler Center for BRCA, Penn Medicine, of which you're leading. Could you give us just an introduction to the organization, a little bit about the history of when it was set up, where you are, and a little bit of I know it, I will obviously put a link to the website in the bio of the show, but clearly you have a lot going on, not just in the education and the counseling, but obviously the innovative research as well as all sorts of other interesting programs. Walk us through a little bit of what's happening at Bassler Center today.
Certainly. So the Bassler Center for BRCA was founded in 2012 at the University of Pennsylvania in the Abramson Cancer Center. There was a transformational donation by our founders, Mindy and John Gray, to get this off the ground. And it was really pulling together components of things that we were already doing at Penn, basic research in BRCA 1 and 2, but also clinical trials, outreach and education, to make a comprehensive center whose goal is to do it all, is to start at that basic level, to understand the basic biology, to make sure that we are taking this into clinical trials, but just counseling, getting people tested that need to be tested. It's estimated that only about 10% of people who have a BRCA1 or 2 mutation know they have a BRCA1 or 2 mutation. And yet there are things that we can do about this. So even just outreach and education, and that's not only outreach to patients, but outreach to providers. So we view education and symposium as an important piece of our work as well. So we're really trying to say, listen, we already know enough about BRCA1 and 2 to help make people better. If they know they have it, we can do things to help them. And that, by the way, is men as well as women. It affects men too. Half the mutation carriers out there are men. So it's important that we don't forget them. But at the same time, we really feel that our current strategies, when we focus on things like removing the ovaries when people are still premenopausal, and all that entails, all the negative side effects that entails, is really not acceptable. So as we continue to try to do our best with the information we have, we want to use our knowledge about basic science to come up with different strategies to reduce individuals' risk of cancer and have a different path forward.
Even at the Cancer Center website, there's quite a long list of the existing open clinical trials. And again, we'll talk about sort of the themes of immunointerception in a little bit, but could you just talk a little bit broadly about, because I see combination studies here with PARP inhibitors, you have some vaccine studies, I think some epigenetic stuff as well. And it goes without saying, because we profiled several of the folks in your really cool ecosystem there, that you're probably the best place to do this, because there are so many innovative approaches to attacking cancer cells happening at Penn. Just walk us through a couple of the sort of the clinical work that's going on, if you would, and then we'll segue after that into immunointerception.
Sure. Now, I think that it's really important to know that although we have made a massive difference in terms of care of cancer patients, and the survival rates of cancer in general have improved significantly. If you look at sort of the last 30 years, survival rates for breast cancer, the death rates have decreased by, depending on the time frame you look at, by 40 to 60%. I mean, these are major advances. And yet we still leave too many people behind, and particularly young women who develop breast cancer, often in this setting of genetic susceptibility. So the clinical trials are really span a wide range. We take individuals who have advanced cancer and we try to improve their survival. And those trials have made such an enormous difference. When you look at the number of drug approvals there have been in breast cancer in general over the last 5 years, it's pretty amazing, pretty astonishing. And so, we obviously are looking at this through the lens of cancer specifically associated with BRCA 1 and 2, but it's worth saying that all these advances in breast cancer writ large are relevant to our patients who also have BRCA 1 and 2 mutations. So all of those clinical trials sort of are underway to try for advanced cancer. But then at the same time, most women who present with breast cancer do so not when it's spread outside the breast, but when it's an early stage breast cancer. So a lot of the clinical trials are in that space. Pancreatic cancer, we haven't spent much time talking about, but pancreatic cancer is the risk is increased in both BRCA1 and BRCA2 mutations, more so for BRCA2. And pancreatic cancer is a very challenging cancer, and so we need better strategies for that. And for prostate cancer, the lifetime risk for a man with a BRCA2 mutation could be as high as 40 to 60% for prostate cancer. So we have really tried to double down our efforts in that disease as well. So we have trials that are specifically focused on a disease site, but also new compounds that might be appropriate for any of these diseases, and sort of things called PARP inhibitors or other drugs that really go across the sites. So those are that space. We also have types of trials where we're trying to understand risk better. So we would like to really understand when people are at risk more immediately. It's all well and good to say someone has a 70% of lifetime risk of breast cancer to age 80, but what a woman really wants to know is, when is my really high risk starting? Like, if I'm considering a mastectomy, can I wait till I'm 50? Do I need to do that at 45? So we've got studies underway there to look at more individualized risk assessment, and also other types of early detection assays. I'm sure you've profiled on this show these kind of multi-cancer early detection assays, which someday are going to be really good. Right now aren't great, but I'm not a nihilist. I think they're going to get there. So we do a lot of trials where we collect serial samples on our high-risk patients, so that someday we'll be able to kind of validate a lot of these assays and put them into practice a little bit more. And then lastly, and I think we're going to talk about this next, we have these interception trials. And what we mean by interception, another word that people often use is prevention, but I'm going to differentiate those terms. They're obviously kind of overlapping terms, but when we use the word prevention, what we really mean by that is that you either do something or you don't do something to prevent the earliest changes of cancer from starting. So for instance, you don't smoke, so you don't impact the cells in your lungs to start those molecular changes that lead to cancer. You don't get a ton of sunburns, so you cause that damage in your skin. When we talk about interception, we're really talking about things that have already started. Like there is a process that has already started. It's not cancer yet, but if we leave it to be, it may become a cancer. And so that's a little bit of a different goal. But the reason we're starting to be more clear about differentiating these terms is because the biology is different. The biology is different if the process has already started. So trying to understand those earliest lesions, understanding everything from the genetic changes to the immunologic impact of those early changes is really going to take a different mindset and potential different clinical trial design.
It's really exciting, and you have this just a couple of weeks ago, I think this paper advancing cancer interception. It's in AACR Journal Cancer Discovery, and here again you outline there's actually a kind of cool chart photo where you have sort of the continuum here, everything from our normal cell to metastatic disease, where we have our traditional drugs and our adjuvants and so forth, and sort of move earlier in the process. And I just like clearly there, as you were mentioning, there's a lot of unknown biology here. And when we think about we always hear about, yeah, here we are as whatever 30-40 trillion cells, and there's all sorts of sort of oncogenic stuff going on throughout our lifetime that our bodies are normally keeping at bay, whether that's various paracrine mechanisms or the immune system or whatever the case may be. What are some of the, I guess, the early targets you're looking at here? Because it struck me as sort of like this is, I mean, it takes something like tamoxifen, right, and breast cancer prevention.
Right.
This seems to be like maybe a little before that. I mean, is my pharmacology in the right? I just sorry if I'm going on because I think it's a really amazing area. Where are we focusing in terms of biologic processes of what's happening in this particular segment that you're going to be focusing on?
Well, there is a lot that is not yet known about those earliest processes. As alluded to, we know that sort of having that you start out with having one bad copy of BRCA, and most of the time when your cancer develops, the second copy is lost. But we actually know, and we know that, for instance, in ovarian cancer, that other molecular changes are common. Something called P53 is also altered. But what the actual series of molecular changes is, whether it's linear, whether this happens and this happens and this happens, or whether it's a little bit more sort of stochastic, but you kind of are, all over the place and you get there in the end, is not clear. We also don't think that these events are random, because if the events were truly random, you would be just as likely to develop a lung cancer than a breast cancer, than a stomach cancer, than an ovarian cancer, right? I mean, why, if it was just random chance that with cell division, you had an abnormality and you lost the second copy, you wouldn't think that they would be clustered in certain organs. So there has to be something specific about how one bad copy goes to two bad copies that allows for what we call tissue tropism. That is a reason that the four cancers predominate. There must be something about the haploinsufficient state, we call it, having one bad copy, that fundamentally leads to the likelihood of losing the second copy. But we're kind of in the early days of truly understanding this. And so right now we have some clues, and we're working on those clues. So for instance, there is a body of work not done by me. This is out of Australia and Austria, looking at a pathway called rank ligand, which turns out to be very important in the development of BRCA1 related breast cancer. So now there is an ongoing international phase 3 trial looking at this drug denosumab versus placebo in BRCA1 mutation carriers to see if it can decrease the risk of breast cancer. And that trial, the hope is to, enroll 2,900 people into that trial to prove that works. So that's an example of basic biology, really looking at that pathway and sort of coming up with this. Now that's only in breast cancer. One of the questions is, could these PARP inhibitors at some point be used for interception? If you think about it as, and I know it sounds like a weird analogy, but like weeding the garden. What if you periodically gave this drug and you took out all the cells that had lost the second copy of BRCA, right? You just killed them off and you got rid of all the weeds. Then you could leave the garden alone again for a while and do it again. Again, this is all speculative, but these are the types of things we're working on. And finally, we are really interested in this area of immuno-interception. I think that, I think it's well established now that the immune system is important in cancer. But, back when I was doing my fellowship, nobody thought that was true, except maybe in melanoma, that people really didn't think that the immune system truly could treat cancer. That was like a pie in the sky idea. And now we have clear reasons to think that that's true. Not only these immunomodulatory drugs, these drugs that can turn on the immune system by cutting the brakes of the immune system. We use those routinely in lung cancer, melanoma, bladder cancer. I'm not going to get them all right. Breast cancer, many cervical cancer, endometrial cancer. So there's many examples of that. And then of course CAR T cells, where we're literally taking T cells out of the body, manipulating them and putting them back in, mostly to treat things like leukemias, lymphomas, and multiple myelomas. So we know the immune system works. So the question is, what can you do with a vaccine? And I think here the term vaccine can be used in many ways, and I want to differentiate it a little bit. There's using a vaccine in people with advanced cancer. I would argue that that's not a vaccine. That's a type of immune therapy. That hasn't worked particularly well. Lots of different reasons for that. There's then using a vaccine when someone's had a cancer and you're trying to reduce the risk of their cancer coming back. And that's an ongoing, very active field. That's an adjuvant vaccine, we would call it, to reduce the risk of cancer coming back. And then there's the area that we're trying to work in, this immune interception or a preventative vaccine, giving a vaccine before the cancer even starts. And in order to do that, you have to choose something for the immune system to react to that is active in your cancers, right? And so, there's lots of different approaches, but the approach that we're taking is to target something called telomerase, which is overactive in 95% of human cancers. And yet in normal cells, it's kind of expressed differently. So it gives us what we call a therapeutic window. So there's been some trials where individuals who, again, had early stage but high risk cancers were vaccinated to this, found for it to be safe, and generated an immune response. And we are now vaccinating healthy BRCA1 and 2 carriers, again, mostly at this stage looking at safety to make sure that we're not generating an immune response that's hurting anybody. But the hope is that we'll continue to be able to develop this. And it may not be this exact target, but the idea is that there is a way out there to get the immune system to recognize early lesions. And we have to be working on the early biology of these lesions and working on our immunologic advances and marry the two to get the best path forward.
With Penn leadership and CAR T and mRNA and everything else going on there, obviously you're in a great spot to collaborate with all those other teams.
I've got some people on speed dial, that's for sure. Yes.
Yeah, that's awesome. And it was intriguing because, I think it was just a couple of days ago that finally, the Geron's anti-telomerase, I guess, drug was finally approved. And I noticed in the literature that you were working on telomerase-related vaccines a while ago. So that's kind of cool as well to see that theme because of the connection with telomerase.
Well, a quick word on that. I think it's important to realize, people sometimes say, well, why hasn't this happened yet? And vaccine technology has changed. I mean, yes, it is true that in my early days, we'll just say, very early days, we were working on things like dendritic pulsed, peptide vaccines, which means taking people's own white cells out, making this certain type of white blood cell, etc. Then we moved to peptide vaccines, which have to be carefully matched to the particular white cell type of a patient. Now we're using what we call DNA vaccines, DNA plasmid vaccines. RNA is clearly of interest, but we get better when technology gets better. Like, it's not, unfortunately, science builds on itself. So sometimes I know that people want us to move faster, but we actually need the knowledge to get better. We can't skip steps, unfortunately.
You've been mentioning, obviously we've been talking about a lot of different genes, and you brought up, P53 before, and obviously telomerase. What's the role here in terms of epigenetics? Because, that seems to be an increasingly hot topic on many fronts in bioscience, but specifically related to epigenetics of oncology. And any interesting things happening on that front at the Cancer Center?
Yeah, I mean, certainly at the Cancer Center, epigenetics, as you alluded to, is when the actual gene is not mutated to be turned on or off, but it is impacted, usually methylated or some other way that it is turned on or off. And I think that there have been therapeutic targets, not in breast cancer so much about how to target the epigenome, but in other cancer types there has been. But what another area of great interest when you start talking about interception is the role of epigenetics in interception, meaning the turning off of the second copy. Like, how does that happen anyway? And what's the role? We know that environmental factors impact cancer development, even in individuals who are at high risk. We know this, but we don't necessarily always understand how and when. And it really probably does matter that a particular environmental insult happens at a particular time. So we can talk about cigarette smoking and asbestos because these are very dramatic, if you will, exposures. But there's probably all sorts of exposures that we're only just starting to understand, like pollution. But it may not be just pollution. It may be the type of pollution and the age at which you're exposed to it, for instance, and on top of your specific genetic background. Microplastics are super interesting, and how they're impacting us epigenetics may be a large part of that, stress, all of these things. I think that we really are just starting to understand, and we have a long way to go on that.
Thing, and I don't know how related this is, but one of my heroes here in the Philly bio ecosystem, who we just lost a couple of years ago, was Bea Mintz over at Fox Chase, and she did this pretty seminal work back in the 70s on how you could take a cancer cell and put it in an embryo, and the cancer cell sort of normalizes. We didn't know what was going on at the time, whether it was epigenetics or cellular competition or whatever was getting rid of that sort of nasty phenotype and creating a normal embryo. Do you see any, when you're doing the germlines work, any interesting genetic magic happening there at that level that do you ever see any interesting reversion events? Or I know I'm sort of talking a little out of my space here, but
yeah, not that so much, but we're complicated. Humans are complicated.
Yeah.
And what we used to, when we used to do genetic testing in the early days, we did it by, Sanger sequencing, it was called. And it was like, not the most efficient strategy for how you sequence things. And now we do, massively parallel sequencing. We used to call it next generation sequencing, but since it's, it's in its teen years now, so we can't really call it next generation sequencing. But that allows us to sequence things more quickly, but it also allows us to realize that some people only have a little bit of a change. So many of us are in fact what we call mosaics. When you look at a Siamese cat and they're different colors. Well, actually, we've got a lot of that going on in ourselves too. And so we definitely know that a lot more people than we initially thought have sort of mutations in only some of their cells and not all of them. So that is something that we've had as our sequencing gets a lot more sensitive. We've actually had to deal with that a lot more, which is, picking these things up, and we're like, okay, is that only in the white blood cells? We call that CHIP, clonal hematopoiesis of indeterminate potential? Is that a technical aberration and it really is germline and that's at 50%? Is it a somatic mosaic? So we've learned all these terms. What I like to tell medical students sometimes is like, terms that I use right now, like on a regular basis, were not terms that we used in clinical medicine a lot, like back in 1995. Like right. You have to learn all the time because we're just evolving continuously. It's what makes it fun, but it also sometimes hurts your head a little bit.
Absolutely. And I enjoy the whole area of somatic mosaicism, and yeah, a lot still to learn there, but no, I appreciate your insight on that. So one thing I wanted to come back to, and you mentioned before some of these, multi-genetic testing tools that are out there now, and sort of the jury sort of still being out on what we can do with all this. And just as a side little note, my father-in-law right now is, he has metastatic prostate cancer. He's got some awesome cutting edge therapies in terms of some interesting antibiotic drug conjugate and all that stuff. But he's given this printout, and he hands it over to me and say, "What does this mean?" And it's a list of like 100 some odd genes there, and I don't know what most of these things do. And I know that this is sort of a core component of some of the work you're doing on the patient education front. And ultimately, what should we be giving to patients, and how do we, in the age of artificial intelligence and all these tools, how do we distill this stuff? Yeah. Talk a little bit about what you're involved in there, especially as we have a lot more of this sort of consumer focused oncogenomic stuff happening in 2024.
Oh, so I could talk forever on this. So one of the issues, as I'm sure you know, is that part of the 21st Century Cures Act means that pretty much all medical record information is automatically released to patients, whether they want it or not, and often before their doctors have seen it or their other healthcare providers have seen it. That creates a real challenge, especially when they're very complex reports. And, the genomic testing reports, be it germline or somatic, can be difficult for providers to understand. And we spend, I'm very fortunate because we have a huge group at Penn. I have a lot of genetic counselors. I'm often sending them things like, can you look at this for me? It takes a village because these are, the reports can be confusing because depending on where you get it done, it can be reported in a different way. I mean, I've had people say, isn't this weird that my patient has 2 different mutations in the same gene? I'm like, they're not 2 different mutations. They're just reported differently in these 2 different labs, right? And these are really smart people. So I think that what we try to do a few things. One, we are a resource. And so we are meant to have people come and see us. We recognize that, we have to empower patients and providers to understand this as best they can, but also realize that we are here for the complex stuff. Does that make sense? Because first of all, there's not enough genetic counselors to see every patient who wants genetic testing. That's just not feasible, and that's not what should be done. So we're really trying to set up systems where we actually, and this is a shocker, embrace the electronic health record. I know, I said it, which I know no one says, but I actually think that you can really do it. And so we've built into our electronic health record a lot of clinical decision support tools. We've also tried to really bring things in as discrete data fields so that they can be more readily analyzed. But you're right, information is only going to get more complex as things come in. It's not that just the genetics, it's the transcriptomics, and it's the proteomics, and we're going to get flooded with this information. And we really need a better way to have the clinical decision support for patients and providers to best use the information. Otherwise, all we do is create complex reports that then are not used to best serve patient care.
Could you say a few words about your young leadership council? Because it seems like here you're bringing together people that may be affected by BRCA, and at the same time may be very important advocates for many others that again have not been exposed to the field.
Yeah, I think that the Young Leadership Council really helps us it reminds us, I should say, of what the most important questions are. Over the years that I've been doing this, so many of my papers have been a patient asked me a question and I don't know the answer, so we go looking at the data that we have. An example is, in the early days, people who had ovarian cancer, would say, well, what should I do about my breast cancer risk now? And, we established, and others also showed, that the risk of breast cancer after being treated for ovarian cancer diagnosis, at least for the first 5 years, is actually quite low. So you're like, just these are practical questions. And, our Young Leadership Council, is really that ask the questions about everything from, fertility preservation to, going through menopause early and symptomatic management to, how you date when you already know you have a BRCA mutation. Like, these are the real world problems that we want to try to help people navigate. So that, yes, they serve as a touchstone for us about what's important. They help really centralize the mission, and they help fundraise for us as well. But really, it's that community, because that's what we need. Even if we develop the hottest thing known to man to intercept cancers, what we first have to do? We have to have volunteers to come and join our clinical trials. And as I vaccinate people right now, do something that has never been given to healthy individuals before, and people just roll up their sleeves and say, sure, I volunteer. I mean, it is quite a humbling experience. So having a shared mission is incredibly important, and keeping our ears open to making sure that we're addressing the most important things of our constituency is vital.
While we have you, what else is coming up for 2024 that we should know about, whether it's specifically BASA related and some of the discovery panels that you host, or just your own sort of conference circuit, places that we can run into you and meet you. Anything else on the calendar that we should know about while we have you today?
Yeah, concert circuit. I like that. It sounds much more glamorous to say that I'm on a lecture circuit. But I think that there's a number of things coming out that are really important. One is that we are trying our best, as are many others, to make it as easy as possible for people to access genetic information. So large number of different studies through Penn and other places to try to make to make it easy to get genetic testing. Sometimes people are put off by bringing this up to their providers and sort of getting a runaround. And we're just trying to make it as easy as possible. And I know that, and we'll continue to do that. I think that that's one really important component. We have a lot going on for men and BRCA, which I think is also really important. Kind of alluded to that several times, but men often are sort of left out of the conversation or not recognized as readily by providers of why you would bother testing a guy. But there are real reasons to do testing. And this is not specific to BRCA1 and 2, but boy, are there a lot of interesting new cancer therapeutics coming out there. You alerted to ADCs, which are these antibody drug conjugates, and that has been really kind of a revolution in breast cancer, but also other cancers. And this is, again, using an antibody to go find a cancer, and then on the backside of the antibody, putting a toxin on it so that there's less drug toxicity. And they've been found to be really particularly effective. So trying to sort of look at what the landscape is, and then saying, okay, bring it over here to our problem, help us solve our problem, is what we're always trying to do.
That's awesome. It's just, it's refreshing to see again, thinking about what you were working on back in the early 90s and see how all this evolved, both on the diagnostics and the therapeutic front. Just, really awesome work, and just wishing you and your team the best with all this as you continue to move it all forward, especially the immuno-interception field, which I just personally find amazing, but at the very beginning of really what's an entirely new domain and in cancer prevention. So no, really, really great work, Susan. for everybody again that's going to be listening to this particular episode of our show across the various podcast networks or watching on our YouTube channel. Again, you've been spending time with Dr. Susan Domchek, Executive Director, Bassler Center for BRCA Cancers, Abramson Cancer Center, Director, McDonald Women's Cancer Risk Evaluation Center, and Bassler Professor in Oncology, Perelman School of Medicine, University of Pennsylvania. Susan, it was really awesome having you. I really want to thank you for taking the time out of the schedule to give us an overview of everything you've been up to and what you're doing. Obviously, thank you for all that you do. And as we like to say here on our show, thanks for helping to create a better tomorrow for literally millions of patients out there. It's really a great story, and I look forward to staying in touch and to continue following your work.
Well, thank you so much. Really a pleasure. And I love talking science. So this has been great.
Yeah.